بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة. اليوم موضوعنا هو pediatric emergencies. We will talk about some important pediatric emergencies. We will start with diarrhea. Diarrhea is a very common problem, especially in infants and young children. It is defined as passage of loose bowel motion due to increased water content of the stool. It is usually associated with an increased number of bowel motion. It can be defined as an increased amount of stool more than 10 grams per kg per day or more than 200 grams per day in adult. In children, normal amount of stool is about 5 to 9 grams per kg per day. According to the duration, diarrhea is classified into acute diarrhea when the duration is less than 2 weeks, chronic diarrhea when the duration is more than 2 weeks. Acute diarrhea accounts for more than 90% of cases of diarrhea. Acute infective gastroenteritis is by far the most common cause. Now we'll talk about the most important complication of diarrhea, which is dehydration. It is the most common and most serious complication and the main cause of death in fatal cases. Dehydration occurs mainly in infants with severe gastroenteritis due to severe diarrhea, severe persistent vomiting, or both. Clinical evaluation of dehydration. First, mild dehydration, representing 3 to 5% weight loss of the body weight, where there is normal or increased pulse, decreased urine output, and the child will be thirsty, normal physical examination. In moderate dehydration, there is 7 to 10% weight loss. There will be tachycardia, little or no urine output. The child will be irritable or lethargic, sinking eyes and fontanelle, decreased tears, dry mucous membrane, mild tinting of the skin, delayed capillary refill and cool, and pale child. The severe dehydration representing 10 to 15% of weight loss. There is rapid and weak pulse, decreased blood pressure, no urine output, very sinking eyes and fontanelle, no tears, patched mucous membrane, tinting of the skin, very delayed capillary refill, and the skin will be cold and mottled. For older children and adults, mild dehydration presents about 3%, moderate dehydration presents about 6%, and severe dehydration presents about 9%. Now we will speak about types of dehydration according to the level of serum sodium. The first one is isonatremic dehydration, presenting about 75% of cases. It occurs when water and electrolyte losses are proportionate. Clinically, the tongue is dry and the skin turgor is lost to the same extent. Serum sodium level is normal, about 135 to 140 milliequivalent per liter. Second type is hypernatremic dehydration, representing about 15%. It is characterized by marked water loss. Tongue is very dry and skin turgor is near normal. Serum sodium level is elevated, more than 150 milliequivalent per liter. And the third type is hyponatremic dehydration, representing about 10% of cases. It's characterized by marked electrolyte losses. Tongue is moist with marked loss of skin turgor. Serum sodium level is low, less than 130 milliequivalent per liter. And the most serious type of dehydration is hypovolemic dehydration because it is usually associated with shock state. But hypernatremic dehydration is associated with some problem with fast treatment. The second complication is shock. Hypovolemic shock and or septic shock with a gram-negative septicemia is a common complication of severe bacterial gastroenteritis. There is poor peripheral perfusion, represented as cold extremities and skin mottling, tachycardia, and hypotension. The third complication is acute renal failure, where there is severe oliguria when the urine output less than 1 ml per kg per hour, or anuria and acidotic breathing. Diagnosis confirmed by evaluation of renal function, elevated blood urea and creatinine levels. The fourth complication is metabolic acidosis. In cases of severe diarrhea, where there is losses of alkalis and severe dehydration, when there is a possibility of renal failure, there is deep, rapid respiration, acidotic breathing. In severe cases, there is altered consciousness. Diagnosis confirmed by blood gas analysis. The severity of acidosis can be determined by the degree of lowering pH and serum bicarbonate level. The other complication is hypokalemia. It is a common complication of severe diarrhea and dehydration. There is abdominal distension, which is the main clinical manifestation. Serum potassium level less than 3.5 milliequivalent per liter. The normal level is from 4.5 to 5 milliequivalent per liter. The other complication is hypocalcemia. It may occur with severe hypernatremic dehydration with a possibility of convulsion or tetany. Calcium level less than 7 milligram per deciliter. Normal level is from 9 to 11 milligram per deciliter. The other complication is convulsion. Causes of convulsion in case of gastroenteritis include febrile convulsion, which is the most common cause, toxic convulsion like in Shigella or Salmonella, metabolic convulsion when there is hypernatremia, severe hyponatremia, hypocalcemia, and in cases of intracranial hemorrhage with DIC. The other complication of gastroenteritis is bleeding, which may occur in severe cases when there is DIC, hypoprothrombinemia, decreased vitamin K, intussusception, and renal vein thrombosis. The other complication is chronic diarrhea and malnutrition, which are present in two types, kwashiorkor and marasmus. And as you know, kwashiorkor usually associated with edema it is more severe than marasmus, usually evident in Iraq. Now we'll come to the management of severe dehydration, which represents a clinical emergency in casualty. There are two types of management, home management and hospital management. We will talk about hospital management of complicated cases. What are the indications of hospital management? What are the indications of admission of a child with severe dehydration? Is the clinical deterioration on home management, severe persistent vomiting with mild dehydration, moderate severe dehydration, presence of other complications as shock, renal failure, metabolic acidosis, convulsions, or bleeding. The most important modality of management is fluid giving or fluid management of dehydration. First, we have initial rehydration therapy, IRT. We have to give a child normal saline or ringer lactate, 20 ml per kg over 20 minutes. It may be repeated until intravascular volume restored and shock state corrected. It can be repeated up to 3 times, especially when there is no urine output. And if there is urine output, we will go to the second step, which is the maintenance therapy. We calculate the maintenance therapy, first 10 kg as 100 ml per kg, second 10 kg as 50 ml per kg, third 10 kg is 20 ml per kg. And we calculate the deficit therapy by the following equation. The amount in mol is equal to body weight in a gram multiplied by percentage of dehydration. Now we come to the method of administration. In cases of isotonic and hypotonic dehydration, the maintenance plus deficit fluids are given in 24 hours as 1/2 in 8 hours and 1/2 in 16 hours. In cases of hypertonic dehydration, we will calculate about 1.25 to 1.5 maintenance fluid and given in 24 to 84 hours according to the level of serum sodium. So in cases of hypernatremic natremic dehydration or hypertonic dehydration, we have to give fluid more slowly to overcome complication. What are the types of fluid? In cases of isotonic and hypotonic dehydration, the fluid will be 1/2 glucose saline plus 20 milliequivalent per liter of potassium chloride for moderate to severe dehydration, or 1/4 glucose saline plus 20 milliequivalent per liter of potassium chloride for mild dehydration. In cases of hypertonic dehydration, 1/4 glucose saline plus 20 milliequivalent per liter of potassium chloride for infants and young children, or 1/2 glucose saline plus 20 milliequivalent per liter of potassium chloride for older children. The other step is replacement of ongoing loss. In cases of diarrhea, we should replace stool, mill in 1 to 6 hours by 1/4 glucose saline plus 15 milliequivalent per liter of bicarbonate plus 25 milliequivalent per liter of potassium chloride. In cases of vomiting, we have to replace vomiting mill to ml in 1 to 6 hours by 1/2 glucose saline plus 10 milliequivalent per liter of potassium chloride. The other step is specific treatment. Diarrhea will usually subside spontaneously within 3 to 7 days without any specific therapy. A specific treatment includes antibiotic therapy. It is usually indicated in severe bacterial infection and not all bacterial infection, specific infection. In case of persistent high fever and bloody diarrhea, drugs are used like methoprim, sulfamethoxazole, ceftriaxone, amoxicillin, erythromycin, metronidazole. Also, antiprotozoal therapy. In case of amoebiasis, we use flagyl or metronidazole, 30 to 50 milligram per kg per day in divided doses for 10 days. Maximum is dose 500 to 750 milligram per dose, followed by iodoquinol. In case of giardiasis, we use furazolidine or metronidazole, 15 milligram per kg per day in divided doses for 5 days. Maximum dose is 750 milligram per day. Also, it is important to monitor the condition of the child by vital signs evaluation, especially pulse and blood pressure, intake and output, fluid balance, urine output and specific gravity, physical examination, weight, clinical signs of depletion or overload, and electrolyte. Now we come to the management of moderate to severe dehydration according to WHO. WHO create a modality of treatment especially for health workers, and it is also important for us. This type of treatment is important to treat the deficit. First, we have to give ringer lactate 30 ml per kg in 1/2 hour, half an hour, then 70 ml per kg in 2.5 hour for children 1 year or more of age, or we give 30 ml per kg in 1 hour, then 70 ml per kg in 5 hours for children less than 1 year of age. This procedure may be repeated according to the correction of deficit, and after that we have to give maintenance fluid by ORS. Thank you very much for your listening.